slides, but I think a lot of them are quick, so they won't be over an hour or anything. But so for this part of the talk, learning objectives are going to be to know the various definitions and manifestations of PCOS, kind of understand the central features, and as best we even understand it, what the pathogenesis or pathophysiology is of PCOS, and then learn how to, or learn what we think is important as far as counseling patients about appropriate therapy, depending on whether they're desiring pregnancy or not, and are just needing kind of maintenance and control of their disease. So polycystic ovary syndrome, especially in older texts, will actually still sometimes get called Stein-Leventhal syndrome. So if you see that, that's what it means, and it's because these two guys, Irving Stein and Michael Leventhal, first described the syndrome formally in like 1935. So they had a short series of patients. It was 7 women who all had kind of the full-blown, what we think of as the full presentation of PCOS now. So they had amenorrhea entirely, no menstrual cycles, they had hirsutism, and they had enlarged multicystic ovaries identified at surgery. So the hirsutism is kind of this male pattern hair growth, coarse terminal hair. So kind of what we talked about, most of the time it's going to at least start in that midline, so you're going to get kind of mustache, chin, under the neck, more extreme cases. So, hirsutism is kind of due to mild elevations in androgens, which is the male-like hormones, tends to be more like PCOS. If you've got somebody that's really like hairy everywhere, that's probably coming from a tumor and you have to go find it. So that is not really what we're talking about today. This series of 7 patients got all treated with an ovarian blood resection, which is not something we do anymore. We've kind of gone to that ovarian drilling I showed you a picture of. But literally just whacked off a chunk of their ovary, and all of them started having normal periods again, and actually 2 of them became pregnant on their own. And this is a pathology, a blurry pathology picture of a polycystic ovary. So you can see all of these follicles on the surface, just beneath the cortex. And if you were to look at this histologically, then you'd see that there are these peripheral follicular cysts, and then hypertrophy of the stroma, which is the tissue in between the follicles. And this is an up close of the stroma. And so who can tell me what type of cysts are characteristic of PCOS? Yep, so it's those follicular cysts. So this is a massive source of misunderstanding between providers and patients, because patients, when they have been diagnosed with polycystic ovary syndrome, they think they have cysts on their ovaries that are going to burst, and that's not really what these do. They actually do the opposite. They don't grow and rupture an egg out the way that a normal follicle would. So it's actually that they are all getting arrested at that antral stage. So we think part of why there may be more antral follicles with PCOS than with women who don't have PCOS is because they may just be accumulating, because again, no single follicle is ever being selected to be the dominant follicle. And another thing that's interesting about ovaries is that that dominant follicle, the one that's going to grow large and ovulate, actually has a signal that we think might be AMH, but don't totally know, that tells the other follicles around it to go away. So that dominant follicle kind of helps continue on with the cycling process, and when you're not having that, you may be accumulating those follicles somewhat. So as we mentioned, at birth, we have about 2 million follicles on average as females, which is less than we had at one point, even before birth. And then for the rest of your reproductive lifespan, those primordial follicles are going to take turns waking up and starting to develop into primary follicles, and then in some case secondary follicles and pre-ovulatory follicles, and ovulate. And it's actually amazing what small a percentage of the total follicle number is going to actually end up ovulating, especially considering now most of the time during reproductive years, women spend a lot of time using contraception that suppresses ovulation. So it's kind of interesting. But this slide is showing typical follicle lifespan. So primordial follicle is a central, this little dot in the middle with the lighter line around it, that is the oocyte. And then there's a single layer of granulosa cells around it. That's the primordial follicle. That one's not waking up or growing or doing anything. It's just sitting there waiting to get the signal to be the one who's next. Once they start growing, then the oocyte is going to increase in size. Initially, there's going to be a second layer of granulosa cells. Then there will be more and more granulosa cells, and then you start to develop this thecocell layer around the outside of it. So it's a primary follicle at this point. And then from there, it's going to continue growing. It gets captured by the gonadotropins that are being secreted from the pituitary. Again, your FSH is most important for this part of things. But this initial part where it wakes up and starts growing and gets up to that primary follicle stage, that isn't dependent on the hormones from the pituitary gland, which is actually why when you're taking oral contraceptive pills or something that suppresses those hormones, you're actually not stopping the process of follicle depletion. But from here on out, then it depends on FSH. So having FSH in the system helps a certain number of the follicles to continue growing, starts to accumulate some fluid. Once it gets big enough to be seen on ultrasound, that 2 to 10 millimeter size, that's an antral follicle. And then the dominant one will grow up to a size often of 20, 25 millimeters before it will then ovulate and release the egg. So much fewer follicles by the time you even hit puberty, about 200,000. And then there starts to be some changes in the hypothalamus and the pituitary. So first thing that happens is your GnRH pulses start to increase in amplitude, particularly at night. And then eventually that's going to increase your FSH, and then you actually start to go through the pubertal transition. Again, that's a whole separate hour-long lecture that we're not going to get into, but once they've started menstruating, it usually takes a couple of years before that whole system is actually mature and coordinated and leads to regular monthly ovulations, but that's the end goal of the system. And so this is showing a periovulatory follicle. So again, when we talk about follicle size, we actually are looking at these, it's an average of the 2 dimensions, so I'll measure across this way and across this way, and the machine will give me an average. So it's usually like 20, 25, the rest of these are antral follicles, and so that one's going to ovulate. The rest of these are just going to undergo apoptosis, and then they become part of the stroma of the ovary. And then in PCOS, you get this follicle arrest. Often you'll hear about this string of pearl appearance to ovaries on the ultrasound that is classic for PCOS, and sometimes patients will have had this appearance to their ovary and get told it by the ultrasound tech when they go and have a pelvic ultrasound, but without any other symptoms of PCOS, they don't have this syndrome. So that all of this can be confusing, and we're going to talk even more about why it's confusing, but simply having the string of pearl appearance doesn't diagnose PCOS all by itself. And a lot of patients who have PCOS, it doesn't end up looking exactly like the string of pearls, but they will have lots of antral follicles when we count them. So we kind of touched on the menstrual cycle at the beginning of the last hour, but there are these dynamics to what the hormone levels are depending on where you are in the cycle, and that's normal. So this is showing FSH is the dotted black line, LH is the solid black line, estradiol is the solid red line, progesterone is this other dotted black line, and then 17-hydroxyprogesterone is shown here, which we'll talk about in a minute. But when you've got somebody who's anovulatory and has PCOS, their hormonal status is pretty much the same any old day that you would check it. So they don't have these dynamics going on anymore. The system isn't talking to each other anymore. And it tends to be the case that LH hangs out kind of high, FSH hangs out kind of low, and then estradiol and progesterone are, in particular progesterone, are suppressed. So there are some theories about what the relationship between all those hormones might be that might get you into this pattern. But there's a lot of like chicken or the egg arguments, so there's a lot of like circular, but we don't know where you enter the circle. So with PCOS, we know often patients have elevated testosterone levels, and that increased testosterone in your circulation actually does have some negative feedback on FSH. It also gets converted to estradiol somewhat, especially if you're obese. That's going to happen in your adipose tissue as well, so that's going to have negative feedback, and that keeps your FSH suppressed. So that's part of why it doesn't get high enough to ever actually recruit a dominant follicle. Since you're never ovulating, then you're never really making progesterone, because again, your progesterone is really only going to be high if you've ovulated in the last 2 weeks or if you're pregnant. And so progesterone feeds back on LH primarily, and so if you're never making progesterone, you're never getting that negative feedback on LH, and so it tends to hang out kind of high. And so the first fairly organized attempt to try to characterize like what are going to be the set of symptoms that we use to diagnose PCOS was in the early 90s. So this came out of a meeting at the National Institutes of Health, so it's called the NIH criteria. This is the official table from the paper, but we're just going to go through it. So after meeting and discussing and all the experts deciding what they thought was and was not important, they decided that chronic anovulation, so infrequent menses or no menses at all, would be criteria number 1. Number 2 would be clinical or biochemical evidence of hyperandrogenism. So that chemical evidence is literally just measuring the blood work. So you check someone's blood, you check for testosterone, or do you guys know what another androgen is? Like another example of one?
DHEA.
Yep, so DHEA, we actually check the sulfate, so DHEAS, because that one tends to be higher in circulation. So you've measured either of those and they're high, or the patient comes in complaining of symptoms that are fairly indicative of having increased circulating testosterone, and so that can be hirsutism like we talked about, but it can actually also be acne, particularly in the hormonally sensitive parts of the face, and so that tends to be kind of the beard distribution. Those are the androgen sensitive follicles, and so those 2 things, plus you have to exclude other causes of anovulation. So these symptoms can't be coming from something else. And so then they have these minor criteria where they recognize that a lot of patients that have PCOS are also going to have some of these things. So insulin resistance, onset of hirsutism and obesity around the time of menarche, so around when they first start menstruating. Elevated LH to FSH ratio, so that's again recognizing that often LH will be hanging out kind of high, FSH will be hanging out kind of low, and they thought that the ultrasound evidence of polycystic ovaries was a minor criterion. So there was a second effort made to define how we're going to diagnose PCOS in 2003, and this was a meeting between the European Society of Human Reproduction and Endocrinology and the American Society for Reproductive Medicine. So they all got together in the Netherlands, in Rotterdam, and decided on a new set of criteria. So now you have to have 2 out of these 3 things, and still you have to exclude other causes of anovulation. So the 3 things are, same thing, chronic anovulation, except now they're saying you could have oligo-ovulation, because we know some women are going to have maybe 3 or 4 ovulations in a year, so they don't never ovulate. It's just kind of unpredictable when they do, so they still count. Still clinical or biochemical signs of hyperandrogenism, and then exclusion of other disorders stayed in, but now they moved polycystic ovaries to become a major criterion. So now you can have somebody who has chronic anovulation and ultrasound appearance of polycystic ovaries, doesn't have anything to do with high testosterone at all, and they can still get diagnosed with PCOS, which actually the NIH criteria you couldn't. So that's the major difference between the 2. And they wanted to be more inclusive because women with PCOS, as we would talk about, are at risk for infertility, and they're at risk for a bunch of other health problems lifelong, and so the thought is that way you have a more inclusive catchment, and so you're more likely to further evaluate and to follow closely more of these women. There's also some argument that that's a much milder presentation than somebody who has signs of hyperandrogenism, and so it will probably, some more pictures of polycystic ovaries, it will probably not surprise you that the Androgen Excess Society, when they made an attempt in 2008 to also make their set of criteria, they included automatically you can only get diagnosed with PCOS if you have clinical or biochemical hyperandrogenism, and then they grouped ovarian dysfunction together, so you can have either anovulation or polycystic appearing ovaries on ultrasound. But that counts as the same checkbox either way. And then everyone has maintained that you have to exclude related disorders. And so part of the reason that some think that the polycystic ovaries are probably not as important to include is that normal young women often will have ovaries with high follicle counts. And we're in this period of transition right now where we're kind of defining what counts as polycystic when you look at an ovary. So we historically have said 12 or more antral follicles on each side, and that was kind of based on Rotterdam. But the European Society is now thinking we should do 20 because that's going to exclude women who have this really like normal egg supplies just because they're young, and kind of avoiding overdiagnosis. And there's even some suggestion that in our like teenagers and really young women, we probably shouldn't even do an ultrasound. So all of this together makes it kind of hard to define PCOS, and whenever you talk about it, you have to specifically say what criteria you're using. If you do research on it, you have to say how you diagnose the people that you included, because there's so many different things that it can mean. So it's difficult for providers. It's difficult even for providers who take care of it on a regular basis like me. It's extremely difficult for patients. So it is a heterogeneous disorder. So you can present with, you know, a variety of different combinations of symptoms. But it is an important cause of irregular menstrual cycles and androgen excess and all the things that can come along with that, like trouble with body image and depression and infertility and all these things that women really struggle with. And so it's still important to try and identify it, even though if at this point it is hard. So, you know, classic PCOS, the way it was originally described, is those same things: the ovulatory dysfunction, androgen excess, polycystic appearing ovaries, when you look at them by ultrasound or in surgery like they did originally. I don't recommend that as first line. And then often there will be obesity, but not all patients with PCOS are obese. So diagnostic tests, kind of your initial workup. To check for anovulation, often your menstrual history is adequate, like we talked about. You can tell, taking somebody's menstrual history, whether they have really regular ovulatory cycles or if they do not. Kind of a more strict definition, so fewer than 9 menstrual cycles per year or over 3 consecutive months without having a menstrual cycle should be a red flag for anovulation. So for your hyperandrogenism evaluation, you're going to ask about symptoms, you're going to examine them for symptoms, although women often are really good at hair removal. So by the time you sit in their office, they're probably not going to have their full beard and full hairiness. So you actually kind of have to ask what it looks like normally, because often, you know, they will have waxed or shaved or whatever their favorite way, laser, and so you can't go alone by just, you know, how they look when they come into your office, whether they are hairy. There are different scoring systems you can use to determine the level of hirsutism. The most commonly used one is called the Fairman-Callway. It's really nice when you're doing a research project to use it. I actually don't use it clinically because to me it's clinically important if it's bothersome to the patient. And so often it will be bothersome at levels that don't meet that cutoff on the scoring system to be full hirsutism, but it's still problematic if it's bothersome to the patient. So that's looking for your clinical hyperandrogenism, looking for your biochemical hyperandrogenism. Everyone's going to vary a little bit in what they order. If you want to get the full thing, total testosterone, you can actually order free testosterone. The lab will check sex hormone binding globulin, and then they actually do a calculation using that and the total testosterone and tell you your free T. That's a lot more expensive. I don't actually use it as often, mainly for that reason. And then your DHEA sulfates, debatable whether to get that or not. But you guys don't need to necessarily be part of the debate, so if you're being complete, you can get the full thing, testosterone and DHEAS. Pelvic ultrasound, again, excluding your maybe teenagers, really young women, you probably don't need that ultrasound to make that diagnosis for them. But in your, especially, you know, patients who are hoping to be pregnant, probably appropriate to get. And then again, this is a diagnosis of exclusion. So what is the most common cause of secondary amenorrhea among women in general. Absolutely. So don't forget to check that. And even somebody who has a long-standing history of irregular cycles, you still need to check it because they might have had a surprise ovulation that they didn't know about, and they might get good news that they actually just recently got pregnant when they come to your office, and we've had that happen. So important to check. And then other things to rule out. So congenital adrenal hyperplasia presents with anovulation and hirsutism. It is more prevalent in certain populations, and it is genetic. It's autosomal recessive, and so I do tend to draw 17-hydroxyprogesterone on my patients who do have bothersome hirsutism. I may not if they don't, but again, if you want to be inclusive and consider 17-hydroxyprogesterone part of your automatic workup, that would never be the wrong answer. So that is going to rule out having this enzyme deficiency. So if somebody has a more severe form of CAH, they're actually probably going to have gotten diagnosed on their newborn screen. With this, we're really talking about the late adult onset, non-classical type of CAH. So that's a 21-hydroxylase deficiency that the mutation is not actually as severe as the full expression of the disease. So they actually are going to have some function of the enzyme. And so they're going to be, backing up their steroid pathway toward androgens and testosterone a little bit, but they're not totally blocking their ability to make like mineralocorticoids and glucocorticoids the way some of these more severe CAH patients are. So the immediate precursor that gets backed up that 21-hydroxylase is responsible for converting is that 17-hydroxyprogesterone. So if it's elevated, then you might have made your diagnosis. If it's mildly elevated, you need to get into a specialist so they can do the additional test. So then, in everybody, you need to check a prolactin and a TSH. Those are totally different treatments to get somebody ovulatory, and so and they're easy enough to screen. So just get your blood work. When prolactin is elevated, often it's coming from a pituitary adenoma. So that can be just a non-secreting adenoma that's compressing on the pituitary. That can raise prolactin, or it can be actually making prolactin itself. But in either case, that's really responsive to medication. So we use dopamine agonists for that one, bromocriptine or cobergoline. And then once you get that prolactin level normalized, as long as that was the only thing going on for the patient, she can start menstruating regularly, and so she can just keep taking her dopamine agonist, try for pregnancy on her own, and then stop it when she is pregnant, because prolactin is supposed to be high in pregnancy anyway. TSH is the only thyroid screen I use routinely. If I get an abnormal TSH, I'll go the next step and get the free T3 and the free T4. But you can screen the whole thing if you want. And then androgen-secreting tumors are what, in my opinion, you are ruling out when you check a testosterone or a DHEAS. Because, if I have somebody who's got some hirsutism, they have already ruled in for that checkbox on the Pcos diagnosis, whether or not the testosterone is high. But if testosterone is really, really high or male range, then I need to go looking for where's that tumor. And so it tends to be that if your testosterone is the one that's high, it's on the ovary. If your DHEA sulfate is what's high, it tends to be on the adrenal gland. And so that's going to determine whether you get a CT to look for adrenals or an ultrasound to look at the ovary. And then Cushing's syndrome is one you really only need to rule out if the patient has actually specific signs of Cushing's. So Cushing's, they're going to have that central obesity. They tend to have these little like toothpick arms and legs because they get that proximal muscle wasting. They often get, you think about the moon facies and the buffalo hump and all of the other fun terms we've come up with for the fact that they kind of distribute their fat differently. And often they'll have abdominal stria, and many obese people have abdominal stria, but with Cushing's they tend to be hyperpigmented. And so with those pigmented stria, if I've got somebody that has kind of that combination of things, then I'm usually screening them for Cushing's syndrome. And so screening test that I use for that is an overnight dexamethasone suppression test, but again, if it's somebody that you've seen and you're kind of worried about it, feel more comfortable sending them along, that would be absolutely appropriate. You can also do a 24-hour urinary cortisol, as my slide says here. Either of those screening tests is equally good, and then if the screening test is positive, then they need to be referred in further evaluation too. So, PCOS is decently common. Like I said, you guys are going to probably encounter, if you take care of women at all, a chunk of patients who have it, have been diagnosed or have some symptoms and need to be diagnosed. It's a very common cause of female infertility in the U.S. We think a lot of the time the onset is right around, well, maybe even before they go through puberty. They may already have that hormonal environment going on, but it doesn't become apparent until they've gone through menarche, and then they have irregular cycles for the first couple of years, like all other girls who don't have PCOS, but then they continue to have irregular cycles or infrequent cycles beyond that first couple of years. We don't really know what causes this yet. There are a lot of theories. It's probably multifactorial, so there's probably kind of a genetic predisposition combined with environmental exposures, like hitting a certain threshold weight for some women. But it's not the same for everybody. When you do family pedigrees for PCOS, it tends to behave like an autosomal dominant condition, but we have not identified a gene that's responsible for it. Probably, there's some studies to suggest that it may have to do with like hormonal environment that they were exposed to in utero. Hard to prove, but we think AMH, like high AMH in mom, might actually predispose the female fetus to have PCOS later, but again, that's very debatable. And then certainly women who have other risk factors for insulin resistance are going to be more predisposed to PCOS. So in adolescence, risk factors include having been born with a low birth weight, so under 2,500 grams. If they started developing pubic hair at a very young age, they may be at a higher risk of PCOS. So that's that adrenarche, so might have an increased androgen production even at a very young age, and that's how it manifests. If they have a first degree relative with PCOS, and if they are obese. So, as I said, the underlying problem is not totally known, it's debatable. Hyperandrogenism is, for the most part, thought to be the main culprit. So that's how this talk is going to focus, but just know that it seems confusing because even the specialists don't agree. So we'll kind of go through the different, arguments for how these various things could contribute. So hyperandrogenism, HPO axis disturbance, and then the insulin resistance leading to hyperinsulinemia. So this is showing where your androgens come from. So we talked about the adrenal and the ovary, and showing just sort of the relative distribution. So testosterone comes from about half the adrenal, half the ovary, because both of these are going to be making androstenedione, which also can be converted to testosterone. That's also kind of half and half. And then the DHEA and also the sulfated version is going to be primarily coming from the adrenal cortex. And then skin is responsible for metabolizing these things and then also converting them into even more potent androgens. So the actual hormone that's responsible for turning a follicle into terminal hair is dihydrotestosterone, and that conversion actually happens at the level of the skin, but it has to have the enzyme. So again, that's a little bit more than you probably need to know to take care of patients, but just for your knowledge, it's that really potent androgen, and so that conversion happens there locally. So in PCOS, just to hammer it home, which organ primarily produces the excess androgens? Ovaries. So ovaries are mostly responsible. And so that's thinking back to our histology picture. You have all these big follicles, and then there's a lot of stroma. It's quite a bit. So ovaries will tend to have a much bigger volume in patients that have PCOS. And part of that's the follicles, but part of it's actually the stroma, that intervening tissue between the follicles. And that's where the follicles that have undergone atresia hang out, and they actually continue to make androgens once they've kind of regressed. And so the more of that tissue that you have, the more androgens your ovary is going to be secreting. So that's that increased theca cell volume we talked about. And there may also locally be more actual LH receptors on the theca cells. So FSH talks to the granulosa cells, LH talks to the theca cells. And so your LH is hanging out really high, and so there's more of it to talk to the theca cells to tell them to make more testosterone, and so then you end up in this feed-forward pattern. And so this is a little diagram showing that. So you've got your theca cell here. There's actually a basement membrane around the surface of the follicle, and then the granulosa cells are on the inside of it. So the theca cell makes the androgens that go into the granulosa cell and get converted to estrogens that go back out into your blood. And so then when your LH is high, you're ramping up this production, and so it's going to make a lot of excess testosterone that's going to go out to your circulation. And then your FSH is low, so you're blocking this conversion to estrogen. So it's just not the local ovarian hormonal environment that you want if you want to be ovulating. So then next we'll talk about disruption of the HPO axis. This is kind of a rehash of some of what we were talking about earlier, so this is just repetition. So decreased FSH, again, because testosterone's kind of feeding back on it. Increased LH because there's no progesterone to feed back on it. Increased LH pulse frequency and amplitude is going to be happening as well, and that's probably a result of changes in the GnRH pulse frequency. And then that increased LH to FSH ratio. So, let me talk about that. So it makes logical sense that starting with an environment of hyperandrogenism can send you into that HPO axis disturbance pattern. So that's part of why we think that may come first. But then again, you know, why you get into that hyperandrogenism pattern in the first place is hard to say. And then insulin resistance, which is thought to be potentially where all of this comes from, but not everybody with insulin resistance gets PCOS. But we know that if you have PCOS, compared to similar weight counterparts, you're more likely to have insulin resistance. So this is showing insulin sensitivity, kind of the inverse of resistance. If you're less sensitive, you're more resistant. So our obese patients with PCOS are the very most, sorry, I just realized my pointer wasn't working. Our obese patients with PCOS are very most insulin resistant or least sensitive, more so than their non-PCOS obese counterparts. But then even among non-obese patients, the ones with PCOS are more likely to have some insulin resistance as well. So there are actually receptors for insulin-like growth factors. There's an IGF-1 receptor in the ovary, particularly on the theca cells. And so with increased circulating insulin levels, you're going to be activating that receptor, and it actually augments the ability of the theca cell to respond to that LH that's in your circulation, so it worsens the release of your testosterone. And then at the level of the liver, that high circulating insulin is going to suppress your sex hormone binding globulin. The reason that matters is because your steroid hormones in your circulation, so your estrogens, your androgens, they're going to be bound up by sex hormone binding globulin. They get bound up by albumin a little bit too, but the part of your testosterone in the circulation that isn't bound is what's available to actually act on your cells. And so if you have more sex hormone binding globulin around, even with the same amount of testosterone production, you're going to bind more of it to that sex hormone binding globulin, and it's not available to actually act on the skin or whatever tissues. And so insulin resistance will actually decrease SHBG production and do the opposite, so you've got more free circulating testosterone, and so you may actually worsen symptoms in that case. And then insulin can actually increase LH secretion from the pituitary, we think, and may sensitize those gonadotropes, the cells in the pituitary that produce LH, to GnRH pulses, thereby releasing more. So all of this, again, feed forward, kind of making things worse. Like I said, insulin resistance all by itself isn't enough to cause PCOS, because certainly there are women who have type 2 diabetes that have high insulin resistance, and they don't all have PCOS, probably only about 25%, but it probably contributes, and so again, that goes into there may be some genetic predisposition. So if you know you've got somebody with PCOS, even if they're normal weight, because of that higher risk of insulin resistance, they actually need to be screened. And so again, we still think hyperandrogenism may come first, but controversial. Depends who you ask and what kind of patients they see and what they do for a living. And side note, we're actually doing some research in my group trying to figure out if there's an autoantibody that might contribute to this. So we don't know yet, is the moral of the story. We do know that once you've established the diagnosis, they're going to need some lifelong care because there are some important clinical manifestations. So, you know, we tend to talk mostly about the reproductive stuff in my field, but that's not all there is. But certainly, these are bothersome to people: menstrual irregularity, the hirsutism, the acne, the infertility, but also contributors to increased risk of cardiovascular disease later in life. And those are important to think about even when they're young and in your office. So that's that insulin resistance we were just talking about, obesity, impaired glucose tolerance, kind of same thing, progressing eventually to type 2 diabetes, dyslipidemia. They tend to have a bigger waist circumference, which can increase cardiovascular risk, all of these things, kind of metabolic syndrome. And then they also have an increased risk later in life of endometrial cancer. We'll talk a little bit more about that in a minute, but so, you know, metabolic syndrome, what contributes to the diagnosis is that abdominal obesity, so waist circumference over 88 centimeters, high triglycerides, low good cholesterol, so low HDL, high blood pressure, and then an abnormal oral glucose tolerance test. So 3 out of 5 will get you metabolic syndrome. Often when I'm doing these tests on patients, I'll just list what they have, but not necessarily say like, yes, no, metabolic syndrome, because even if you've got 2 of them, they've got an increased risk of cardiovascular disease later. So screening includes a 2-hour oral glucose tolerance test, which is a 75-gram glucose load. They get serum drawn fasting right before they drink this, which doesn't taste amazing, and then they have to hang out without eating anything else for 2 hours. They get their blood drawn at 1 hour and 2 hours. And then some providers have gone to using hemoglobin A1C as a screen. That is not officially what's recommended right now. Fasting lipid profile, and then you get your vital signs, your blood pressure, waist circumference if you're concerned, and then again, plus minus an endometrial biopsy. So the reason they're at increased risk of endometrial cancer, actually there's a few reasons. So obesity all by itself is a risk factor, diabetes is a risk factor, and so they may have those co-occurring things. But endometrial cancer, at least the most common type, is actually caused by a hormonal environment where you have exposure to estrogen and then pretty much never progesterone. We call that unopposed estrogen. And so, if you think about the way your menstrual cycle works, that follicular phase, your estrogen is going up and that thickens up the lining, kind of gives it this proliferation signal, and so the cells just grow and divide and grow and divide. And if you ovulate, then you've got progesterone around for a couple weeks, and that's going to bring in extra blood vessels and increase the diameter of the glands and increase secretion and kind of get ready for an implantation. But if you never get that progesterone signal, then the lining's never really going to organize. It's just going to get that signal to grow. And so that's part of why they get these irregular bleeding patterns actually, is part of it'll overgrow its blood supply and kind of shed, but it's not this nice organized shed that you get when you have a menstrual period that is because of a progesterone drop, because you get these nice organized, it's what causes the cramping, you get these nice organized contractions, so everything will kind of come out at once. It doesn't happen when you're just having anovulatory bleeding. So you bleed a little bit here, a little bit there, and then if enough of the basalis gets exposed, then you can have really, really heavy bleeding actually, because those blood vessels become exposed and the uterus isn't doing that organized cramping to clamp them off. Or it can hang out stable for a long time and just grow and grow and grow, and you can go a long time without bleeding. So that proliferation for years and years contributes to a precancerous condition that's called hyperplasia, and then that can turn over time into actual endometrial cancer. And so the way to combat it is actually make sure they're getting exposed to either progesterone through ovulations or pregnancy, or through progestins, so progesterone-like hormones, through, there's lots of options that we'll talk about, but most of them are found in your various hormonal contraceptives. And so that's what's going to decrease their chance. So it's really important to recognize. So treatment for PCOS is kind of symptom dependent and patient goal at the time dependent. So you know, whether they're trying for pregnancy, actively, if they are, you want to treat their infertility. If they're not actively trying for pregnancy, you don't need to focus on that. You need to protect their endometrium. If their skin manifestations are very bothersome, there's some treatments for that. If their dysfunctional uterine bleeding is very bothersome, there's some treatments for that. And then the obesity and diabetes prevention is lifestyle changes, so that's the hard part. So for infertility, it's really about getting them to ovulate for the most part. And I usually like to offer the rest of the fertility workup because, you know, that would be a bummer to, you know, get them ovulating and they try for a year, and at the end of that year you find out that their partner had terrible sperm counts. So we just go ahead and get the semen analysis on the front end, and I check their tubes if they've got risk factors, but not if they don't necessarily. So often we're having a chat about weight loss. That's part of the preconception counseling. And it's actually a way to treat the anovulation for some patients, because if they're obese and they have PCOS, they have a chance of starting to ovulate spontaneously, even if they lose as little as 5 to 10% of their body weight. And so they may not get to a normal BMI with that, but if they can flip themselves into ovulating, they actually don't need me, which is nice. And they're also going to decrease their risk for those adverse outcomes in pregnancy that come along with obesity. So that's a nice place to start. And then we talked about the other ovulation induction agents. So clomiphene citrate was first line for years. Aromatase inhibitors have become first line according to the American College for Obstetrics and Gynecology because of that study I showed you. And then for patients who don't respond to those, we have the injectable gonadotropins. In only specific cases, the laparoscopic ovarian drilling, and then sometimes we'll use these insulin lowering medications in conjunction with these other things. They're not that good all by themselves to help people to ovulate. So on that topic, metformin is the insulin sensitizer that's traditionally been studied and used in PCOS. So it's an oral bigronide. It's kind of works by decreasing hepatic gluconeogenesis and is going to increase peripheral glucose uptake. It's nice because you can use it in people who don't have full-blown diabetes, and you're not going to make them be hypoglycemic. You don't want to give somebody insulin if they don't have diabetes, for example. And it does increase insulin sensitivity. So that was thought for a while to be good enough all by itself to help a lot of women with PCOS to ovulate on their own, but we have since discovered that's probably not true. They probably need to do it in conjunction with you know, these other specific ovulation induction agents, and it probably helps the most in patients that actually have insulin resistance. So I actually test for that, and I tend to only put my patients on metformin if they actually have insulin resistance, because it's going to help them hopefully sensitize to ovulation induction, and then it will hopefully also decrease their risk of getting diabetes later in life. Might help with a little bit of weight loss too, maybe, but not as much as they want. So then for skin manifestations, we're going to talk about some various treatments. So oral contraceptives we consider first line, and then there are some antiandrogens that we're going to go over specifically. So oral contraceptives work to stop the pattern of increasing hirsutism, but they're not going to get rid of, none of these treatments are going to get rid of hairs that have already become terminal hairs. You actually have to do permanent hair loss techniques to get rid of those, and so that can be, you know, like laser electrolysis, or you can do your maintenance, whatever, but none of these treatments are actually going to reverse a terminal hair back to a non-terminal hair. So what they've got as far as their hairiness, that's not going to go away, but you can help to decrease progression to more hairiness with some of these treatments. So the OCPs actually increase your liver's production of the sex hormone binding globulin that we talked about. So that's going to mop up more of that circulating testosterone. So you're going to have less free testosterone, you're going to have less acne, you're going to have less terminal hair creation. So it also has the added benefit of containing an estrogen and a progestin. Like we talked about, that's important for decreasing the risk of endometrial cancer. It's going to make their menstrual cycles regular so that they know when on earth they're coming. You can even give them continuously and help them not even have cycles. So if you have abnormal uterine bleeding, it's a good treatment for that. So it accomplishes a lot of things. This is kind of first line for anyone with PCOS not trying for pregnancy at the moment to accomplish a lot of their goals. I think I said everything on that slide already. The antiandrogens that are sometimes used besides that, spironolactone is probably the most common one. So that's actually a potassium-sparing diuretic, but it actually works as an antiandrogen. And so for women whose hirsutism isn't controlled well enough with OCPs, this can be added. You just cannot prescribe spironolactone and Yaz or Yasmin at the same time because they both work as potassium-sparing a little bit, and so you can actually create a situation where they've got hyperkalemia. So if you're gonna use spironolactone, it has to be with any other birth control besides that. But they do need to be on contraception when they're using spironolactone, because if they get pregnant and it's a boy, then they're going to have an antiandrogen in their system, and that can actually mess with their development. Pretty effective. Flutamide is used occasionally in patients who don't respond to spironolactone. This one's a non-steroidal antagonist that acts at the nuclear androgen receptor. And then there's one that in the literature sounds kind of nice to have, but isn't available in the US. They might read about occasionally. You guys don't need to know this for clinical practice, but the cyclodrone acetate's pretty good too. So then, Mike kind of talked about treatments mostly symptom dependent. So if they're having a dysfunctional uterine bleeding, or they've got any pattern that makes you think anovulation for a period of longer than a year or two, I recommend that you consider an endometrial biopsy or send them to someone who can do it. And then again, they'll want to be on oral contraceptives, or you can do cyclic progestins. So that can be progestins by themselves, like norethindrone. It can be Provera. So you can take that for like 10 days and then stop it. They'll have a period at the end of the, it kind of mimics the luteal phase where you have a progestin in the system for almost 2 weeks, and then withdraw it, stop it, and then they'll have a period after that. So you can do that once every 1 to 3 months. You can use even ergestrel IUDs. That's a progestin, so that gives them that endometrial protection, but they might still have unwanted spotting with that one. You can use Nexplanon, you can use Depo-Provera, but I think I've already made clear that's not my favorite. And then you want to talk to them about lifestyle management. So it is easier to gain weight when you have PCOS. It is harder to lose it. But there's not a magical medicine I can bring on board that's going to necessarily make that different. And it's maybe a little harder than the baseline population, but it's hard for anyone. And so we often, for patients who are trying to lose some weight, we'll have them come in for kind of monthly visits to have some accountability. If they want to go into a program, that's probably going to be even more effective, where they have even closer accountability, but that's kind of what we're able to do in our practice. And so we'll even occasionally have people on pharmacologic agents for a short period of time. Phentermine we'll use occasionally, and Orlistat, which is over the counter. Phentermine does, you have to monitor your blood pressure pretty closely with it, because it does increase chance of hypertension. So some safety with that one. Orlistat, pretty much anybody can take, but if you eat too much fat in your diet, then you're going to see it in your stool. So you can get the terrible fatty diarrhea and even incontinence with that one. So you have to warn people. It's going to let you know if you ate too much fat in your meal. So diet and exercise is the most effective way to reduce their chance of future cardiovascular disease, maintain weight, decrease risk of diabetes, all that good stuff. But Metformin can also decrease chance of diabetes. I think I just told you the answer to this one. So diet and exercise, right? So again, you lose some of your adipose tissue, you're going to increase your sex hormone binding globulin, you're going to decrease your testosterone production, you're going to improve your insulin sensitivity, you're going to kind of reverse that bad pattern that you've been in. Very hard to maintain long term though. So you know, if you take on patients like this, you got to be ready for like the emotional roller coaster and be there for support for them. It's tough. Okay, so summary, initial evaluation, H&P, testosterone in some way. I like to get total, TSH and prolactin. You can also consider DHEA sulfate, 17-hydroxyprogesterone. You can get LH and FSH, and then pelvic ultrasound if they're of an appropriate age. And then once you have the diagnosis established, you need to rule them out for these other cardiovascular risks, and they also need to get periodic screening with that glucose tolerance test, the lipid profile, blood pressure, and then endometrial biopsy when indicated. And always remember they need to have their endometrium protected when they're not trying for pregnancy. So like we talked about, treatment depends on what symptoms they're having and what their goals are. If they're obese, you need to encourage a healthy diet and exercise. There's been some thought that patients with PCOS may do better on kind of a South Beach diet sort of thing where you stick with low carbs or that lower glycemic index carbs. That has not honestly totally panned out in the research, but if that helps them think more about like, what am I eating and am I going to cook at home more and that kind of thing, then I don't think it's a bad thing to recommend, to be honest. If pregnancy is desired, then they're going to need ovulation induction with Clomid or letrozole, and then if they don't desire pregnancy, OCPs, and then Metformin if they have insulin resistance. If they continue to get worsening hirsutism on the OCPs, you consider adding spironolactone, and then anticipate that this could be a lifelong issue because it tends to be. Okay. Which of the following is considered the primary pathophysiologic defect in PCOS from our current understanding?
A.
Yes. First one. Okay. All right, any questions about that?